Hi everyone, good evening. So let's start. It's okay if we are 3 minutes earlier. People will be joining by the time, no problem. Okay. So yesterday we have started our class, our course with the pathophysiology of clot formation, and we discussed the entire, antiplatelet cascade of the clot formation, right? And what are the indications of antithrombotic agents? What are the three types of antithrombotic agents? I mean, commonly, right? So we will be continuing yesterday's class, and why I wrote that today's class is going to be awesome, because we are going to discuss some more pathophysiology and then all drugs. Okay, all drugs with doses, multiple questions. There are many things for you. There are many things, many questions for you, many answers. You will be getting for your questions, and there is a there are a lot of new things to learn today. Okay, many of you might have attended my this class before, but today as I have started teaching with this pen and note. So today's class, I believe, is going to be more awesome than the previous ones. Definitely a lot of improvements and a lot of new things to learn. So let's start. Let's not wait much. Let me share my screen. And I believe that teaching here is something really good. Teaching on OneNote is quite good. Why it is? Why I'm liking it is because I can share the PDF. I can save it as a PDF and share with you guys. That's the best thing. So I can share the recordings as well, and I can share the material as well. So here you will get all live things to read as well, right? As a material. So let's start with the class, guys, because today's class may go for 1.5 hours. Okay, because today's class is quite interesting and it is quite long. No, not many slides, but few pictures and few text. Okay, but let's see how it goes. So let's start, guys. So first of all, let's start with revising the last module. Means yesterday we discussed about the clot formation. We discussed about the clot formation, right? We discussed about the clot formation with the help of these three steps. First is endothelial injury, then the entire platelet cascade, then third is coagulation cascade. So we have discussed the entire platelet cascade, how one Wilbrand factor comes out, how the collagen comes out from the injured site, and how it binds to the platelets and activate them and then aggregate them along with multiple other elements which are already present in your blood and your circulatory system, right? After that, alongside, there is another cascade which is coagulation cascade. So we started the coagulation cascade. We understood it with the little factors. Okay, we did not go much into the clotting factors. We did not go into the coagulation cascade completely. So we will understand first the coagulation cascade and how it helps in creating the fibrin, or ended up with the fibrin, and from the thrombin, and then how it binds with the platelet and how it make the mesh. Okay, and how it makes the plaque, right? So entire plaque formation we'll discuss, and then we will be discussing about individual drugs. We will be discussing about individual drugs. So see, first cascade we already discussed yesterday. Okay, first cascade we already discussed yesterday, that was platelet cascade. But today there is another cascade we are talking about, that is coagulation cascade. So guys, first of all, there are two types of pathways in the coagulation cascade. There are two types of pathways in the coagulation cascade. Let me show you like this. Okay, so first thing, if you can see here, first thing is intrinsic pathway. Okay, first thing is intrinsic pathway, and second thing is extrinsic pathway. So can someone tell me what is extrinsic pathway and what is intrinsic pathway, guys? Can someone tell me what is extrinsic pathway and what is intrinsic pathway? Tell me something. What is the exact difference between extrinsic pathway and intrinsic pathway. What is intrinsic pathway, guys? Tell me. I'll make it very simple for you. You might be scared of the pathways, coagulation pathways, but I'll make it very simple for you so you will not forget it ever. I'm very sure. Okay. So tell me if you know what is the exact difference between intrinsic and extrinsic pathway. Intrinsic, okay, so someone is writing, Arun is writing, sir, intrinsic pathway takes place only when the injury takes place. Okay. Intrinsic follows the endothelial damage. Okay. Extrinsic outside, intrinsic inside. Oh, this is, don't go with the name. That's totally opposite. Okay. And it gets activated by extrinsic pathways. Okay. So, you have quite different theories, definitely. But let me tell you. Okay, let me start telling you here. See, when there is a vessel, right? This is the vessel and this is the injury site. Okay, this is the injury site. This is the injury site. Okay, so from the injury site, there are multiple factors coming out for the platelet cascade. Those are von Willebrand factor, right? Okay, then there are collagen, right? Those are taking part in the platelet cascade, and these are two major things. And then alongside there is one more thing coming out, tissue factor. Okay, tissue factor. Okay, tissue factor is coming from the injured site, that is secreted from the endothelium. Okay, tissue factor is secreted from the injured site. Okay, injured site. So this tissue factor is coming from the injured site, and this is called as extrinsic pathway. Why it is called as extrinsic pathway? Let me tell you. When we are talking about the plaque formation in the vessel, so the inside thing is what is floating inside the vessel. Okay, whatever is floating inside the vessel, the circulatory system is the is the intrinsic pathway, is the if we say in another words, those elements are intrinsic materials, intrinsic elements, like RBCs, or if we are talking about platelets, if we are talking about TLCs, anything. Okay, and if we talk about the coagulation factors, then there are multiple coagulation factors also which are already available internally in the blood. Okay, there are multiple factors, multiple coagulation factors which are already available inside. When I'm talking inside the blood, that means I'm talking about circulatory system, right? And when I'm talking about inside, that is intrinsic pathway. So all the factors which are already available in the blood circulatory system, so that is intrinsic pathway. That pathway, I mean, all the things, all the elements which take parts in the clot formation or plaque formation, those will be going to the intrinsic pathway. Okay, that pathway of the coagulation called as intrinsic pathway. And whatever is coming from outside means secreted from the endothelium. Okay, understand, whatever is secreted from the endothelium, that is coming from outside to the blood, that is coming from outside to the your intrinsic elements to the blood, to the circulatory system. So tissue factor is intrinsic, not intrinsic, is extrinsic element here. Tissue factor is an external material here, right? Okay, so let me
please mute your microphone.
No problem, guys. That's okay. I have muted every one of you. I'll be opening at the end of the class. No worries. That's okay. That happens when there are a lot of people. That happens usually. Okay, so no problem. So when I'm talking about external materials, those are not from the blood. Those are not the blood component. Those are coming from the outside. And outside means here not going through your mouth or not going through your other injuries or injured sites. Those are coming from the endothelium, right? And those materials are external materials. So external material here is tissue factor. Okay, and internal material means all the coagulation factors which are already available in inactivated form. available in inactivated form in the blood only. Okay, these are blood components which are there already in the circulatory system in inactivated form, and when they come in the contact, or when they come in the contact with the damaged surface, right, when they come in the contact with damaged surface, they gets activated. And what are those factors? Let's understand. 12, 11, 9 and 8. 12, 11, 9, 8, and then it comes to 10. Okay, so sequence is little different. Otherwise, this is 8 to 12 only. Okay, this is 8 to 12 only. Right, all the factors which are intrinsic, or which are available internally in the blood are nothing but 8 to 12. Okay, 8 to 12 coagulation factors, right? But the sequence is how it goes. Let's see here how it goes in the intrinsic I'm talking about right now first. So when there is injured site, all the blood coagulation factors, okay, which are already there in the blood, comes in the contact with damaged surface and gets activated, okay, one by one. Like first 12 gets activated into 12a, right? Then 12a activates 11 to 11a. Then 11 gets activated 11a, and 11a activates 9 to 9a. Then 9a activates 10 into 10a, and parallelly 8 activates into 8a, and then 8a again, I mean here 9a and 8a, both 8 and 9 activated. 9 and 8 both activates the 10 into 10a. Okay, 10 into 10a, and 10a activates the prothrombin, which is second coagulation factor, second to thrombin, second a, and then second a means thrombin activates the fibrogen, which is 1 to 1a, which is fibrin. And fibrin is nothing but your fibrin cross-linked clot, which makes the mass around the platelets and other factors and make the plaque strengthen. Okay, make the plate, the plaque strong. Okay, now this is just the intrinsic pathway. If we talk about extrinsic pathway is lesser than the 8, like 7. Okay, so this is like only the tissue factor which is coming out from the injured endothelium, and it activates because of the trauma, only because of the trauma. Whenever it comes out, the 7, whenever it comes out, the tissue factor comes out, it get the 7 to 7a, it get the activated 7 to 7a. And 7a also, not only 8 but 7a also, if we get it either this side or this side, this is also activating x to xa. Okay, so now only not 8 and 9, but v2, v3 and ix, means 7, 8 and 9, all these three factors activate 10 into 10a. Got it? Got it, guys? So when I'm talking about intrinsic, like it is from where, simple, you understand here. 12 activates 11, 11 activates 9, 9 activates 8, and 8 and 9 both activates 10 along with 7 from the different sites. 7 get activates from the tissue factor. Okay, 7 gets activated from the tissue factor, and these all come together and activate second to second a, and second a, and second a activate first to first a. Okay, first a is nothing but fibrin. Okay, and fibrin makes the clot strong. Understand, guys, it is very simple phenomena. It is very simple phenomena. So you have to understand what is intrinsic, what is extrinsic. So intrinsic is what is already available in the blood, and extrinsic is what is coming from the injured site. And from the injured site, only 7 and tissue factor is coming. So tissue factor is activating 7 into 7a, and again 7a is activating x into xa, means 10 into 10a. And other side, Intrinsic means starting from 12 to 12A, and 12A is activating 11 to 11A, and 11A is activating 9 to 9A, and 9 is activating 10 again. Okay, and alongside it is also activating the 8 to 8A, and 8A is also activating 10, right? To 7, 8, 9, all three are activating 10. Okay, and not only these, but guys, 5 also activates the second, not only the 10. Okay, not only the 10, but coagulation factor 5 also activates the prothrombin into thrombin, right? From the other side means activated protein C. So whenever there is injury, some proteins are also gets activated, some proteins are also getting activated, and those proteins are activating the factor 5. Okay, and those proteins are nothing but activated protein C. I mean, protein C is getting activated, and activated protein C is activating factor 5, and factor 5 is activating X. So X means 10 is activating. So see here, the most important and strongest factor is 10. Okay, which is converting the prothrombin into thrombin. Okay, and to why there are multiple factors which are just activating X, because X is needed to activate the prothrombin into thrombin, and then thrombin will convert fibrinogen into fibrin, right? So this is the simplest cascade to understand, there are two ways, there are two pathways, one is intrinsic and one is extrinsic. So any question here, guys? Any question here to understand? Any questions for me, guys, here at this pathway, at the coagulation cascade? If you have any questions, please ask me now. No. Okay, so this is the second part of your platelet aggregation and plaque formation. Okay, so this is I mean the second step, or we can say the third step, because first is injury, and then after injury, platelet aggregation and activation, and after that, I mean, activation first and then aggregation, and then it comes to the coagulation cascade. That but those two, I mean, these two are parallel cascades. Okay, and making the final product, that is plaque. Okay, so here you can understand easily, right? See, intrinsic pathway, first 12, then 11, then 9, then 8, and then 8 and 9 are activating 10, and from this side 7 is activating 10, and from this side 5 is also activating 10, and then 10 is converting prothrombin into thrombin, and thrombin is converting fibrinogen into fibrin. Simplest way to understand, and that makes the clot, like these are platelets, these are platelets, these are platelets, and these are getting strong by fibrin. So this is the plaque inside your vessel, and this is stopping the way of blood flow and creating the hypoxia, and hypoxia is creating oxidative stress. Understand this, hypoxia is creating oxidative stress, and oxidative stress is causing myocardial injury, that is myocardial infarction also, and that is called as heart attack. This is the simple process of having the heart attack. You understand? First thing, you understand the entire cascade of clot formation, right? Clot formation. Okay, clot formation is done. After clot formation, there is the blockade in the blood flow, and once there is a blockade in the blood flow, then there is no sufficient oxygen supply. So the demand of oxygen is not meeting inside the vessels, inside the heart, inside the tissues of the heart, and because of that, oxidative stress gets, I mean, there is the high level of oxidative stress, and due to oxidative stress, myocardium is injured. Myocardium is nothing but the vessel, inside the vessel, or the inner lining of heart. Okay, inner lining of heart, that is getting injured, and due to that, there is heart attack. That is also known as heart attack. Myocardial injury or myocardial infarction is called as heart attack, right? So this is the simple phenomena of having heart attack. Understand? I think you know that now. So now there are antiplatelet agents. Okay, I'm talking about antiplatelet agents. Yesterday we talked about antithrombolytics also. I mean the thrombolytic agents, not antithrombolytic, thrombolytic agents, right? There were three types, right? There were three types. One is antiplatelet, right? Antiplatelet agents, right? And number 2 was what? Number 2 was anticoagulant, right? Anticoagulant. And number 3 was what? Number 3 was thrombolytics. Thrombolytics, right? Thrombolytics. These were the 3 drugs which can help in the what? Which can help in preventing the heart attacks, which can help preventing the plaque formation and the heart attack or the myocardium injury or the myocardial injury. That is the normal phenomena, right? So antiplatelet drugs are nothing but to use these are used to stop the clot formation by inhibiting the platelet aggregation, adhesion, and activation, adhesion, and aggregation. Okay, so these all antiplatelet drugs can work on the work on the inhibition of platelet activation. If there is site injury, then these will stop platelets to get activated. Okay, these will stop platelets to get activated and aggregated to each other, right? Let me show you how it goes. Let me show you how it goes. See, this is the injured site. Okay, bigger, like I'll show it like this is zoomed in. Okay, we have zoomed in the injured site. So this is the injured site, multiple factors are there, right? Now let's see, these are the platelets. Okay, this is one of the platelet. Let me show you, this is one of the platelet. Okay, this is another platelet. Okay, try to understand it, very important to understand. Okay, this is the third platelet. Let's see, these are the platelets, similar or almost similar size. Okay, so this is the platelet and this is the surface of platelet, right? This is the surface of platelet. Every platelet has surface, right? So on the platelet surface there are, look at this, very important, there are gp2, usually we write this, and gp2a 3, gp2b3a receptors. Okay, receptors. There are von Willebrand factor receptors. Okay, and there are collagen receptors. Okay, receptors on the platelet surface. So how does it look usually? See, suppose usually these are the gp2b3a receptors. Okay, and then this is the von Willebrand factor receptor. Okay, this is the von Willebrand factor receptor. And then suppose this is the collagen receptor. This is the collagen receptor. So what happens is, how it gets activated whenever the platelets are flowing in the blood, right? This is the blood, this is the circulation system. So these are flowing inside the our circulatory system, and these have seen this injured site, right? So there are multiple factors which are secreted, like von Willebrand factor. Okay, first is von Willebrand factor. Okay, second is collagen. Okay, collagen, important. Two factors are very important, von Willebrand factor and collagen. So what happens is, suppose this is the like von Willebrand factor. So I'll just see, this is the VWF, which is coming out of the injured site. So this will come to this receptor here. Okay, at the platelet. This will come to the platelet at the von Willebrand factor receptor. This VWF will come to the receptor and get attached. It gets attached here. So on one platelet there are thousands, not only thousands but millions of the receptors. Okay, not only one, I'm just showing you a few, but there are millions of the receptors on the platelet. So these factors will come and bind here. Similarly, there are some collagens, which will come, again, the collagens are, suppose this is suppose this is the size of collagen, this is the collagen type. So this will come here and bind to this collagen receptors. Okay, and then this is again, the collagen factor will come here and bind with all the collagen receptors. Okay, all the collagen receptors. Along with that, there are multiple other receptors, multiple other binding receptor, platelet binding receptors. Okay, multiple other platelet binding receptors. Okay, platelet binding receptors we call them. So what happens when this platelet gets activated? This platelet gets activated, these factors from the injured site will come and bind with this platelet, and they will attach this platelet, or this platelet will just go and attach to the injured site. Okay, this got activated and it is now attached with these factors and attached to this injured site. Okay, now what happens is there are other factors, like there are other receptors which are called as platelet binding receptors. So what they will do is they will call, or they will invite, or they will catch. Okay, catch, invite, call. Remember, catch, invite, call other platelets to get bind with these platelets and bind with these other factors. Okay, so other platelets will come here to the injured site and these will bind together. Okay, so this is how the process starts. This is how the process starts, right? So whenever I'm telling you this micro mechanism, this is the micro mechanism of the plaque formation. Okay, this is the micro mechanism of platelet aggregation and platelet adhesion and platelet activation. Okay, why I'm telling this is when I'm talking about antiplatelets, there are multiple types. Okay, there is one thing which is GP2b3a inhibitors. Okay, there are another things COX inhibitors, right? There are another things P2Y12 inhibitors. Okay, so this is when I'm talking about GP2b3a inhibitors. What they do is they just the drug tyrofenin or whatever you are giving, this will come instead of these factors. Remember, instead of these factors, the drug will bind to the platelet receptors and occupy the place. Understand? Drug will bind to these receptor and occupy this place. So there is no place to bind with these factors at injured site. So this will stop preventing or stop or prevent the clot formation or plaque formation, or this will slow down the plaque formation. Okay, this will slow down the plaque formation. This is about when I'm talking about GP2b3a inhibitors, right? This is how it have how it works. This is how these drugs work here at this site, and that's how these prevent the platelet aggregation, right? When now I'm talking about the second thing, COX inhibitors, right? COX2 inhibitors. COX2 inhibitor is only one, aspirin usually, right? Only one drug in this category, aspirin. So how aspirin stops that? Aspirin come and this is the COX. This is the COX receptor. When I'm talking about platelet binding receptor, that is the COX receptor. Okay, that is the COX receptor, and COX is the another hormone or factor we can say which is secreted along with other factors from the injured site as well. Okay, so aspirin will bind with the COX receptors at the platelet site. Okay, platelet site, it will bind with the COX receptors and it will inhibit the COX binding. Okay, so again it will stop the platelet activation and aggregation, right? Number two. Number three, the mechanism is there are not only the COX receptors or GP2b3a inhibitors or collagen receptors, but there are ADP receptors also. Okay, ADP receptors. Okay, ADP receptors, and this is called ADP mechanism of platelet binding. ADP mechanism of platelet binding. So what happens is there are ADP, ATP molecules which are also secreted from the injured site and converted into ADP, right? And now this ADP, ADP is the pro-hormone of CYP cytochrome 12. Okay, this is the pro-hormone of cytochrome 12, and this is the main energy source of platelet binding, ADP receptors. So ADP is coming and binding on the platelet surface again and activating the platelets. So ADP is the major thing, major energy source which is activating the platelets. Okay, see, everything is everything is activating and binding, but ADP is the major source of activation of the platelet. Other things are aggregating the platelets together, right? Other things are aggregating the platelets together and catching to the injured site, but ADP is the major element which is activating the platelets to come to the injured site and to catch other platelets, right? So now this is being stopped by what? ADP inhibitors, ADP receptor inhibitors. And what are those ADP receptor inhibitors? Cytochrome P12, I mean this P12 inhibitors. What are those things? Clopidogrel, prasugrel, ticagrelor. These are cytochrome P12 inhibitors, right? These are cytochrome P12 inhibitors. So that's why to compensate more, to compensate the most of the binding and activation, we give two drugs altogether. One is aspirin and one is cytochrome P12 inhibitors, right? Cytochrome P12 inhibitors. Understand, guys? So this is the basic fundamental mechanism of clot formation and drug mechanisms, how the drugs work here, right? So let's understand one by one. Let's understand one by one how it actually works. See, look at this. These are the drugs used to stop the clot formation by inhibiting the platelet activation. So multiple mechanisms, as I told, then adhesion and aggregation. So indications are, see, if I'm talking about the indications, then I'll just write here. I'll just write here antiplatelet drugs. Okay, antiplatelet drugs. Where we can use them, guys? One is your MI, okay, myocardial infarction, then stroke, normal stroke, then ischemic stroke, transient ischemic stroke, okay, transient ischemic stroke. This is not hemorrhagic stroke, guys. Okay, still this is not hemorrhagic stroke. One is ischemic stroke, one is transient ischemic stroke. Okay, this is the difference what you have to read by yourself, like between ischemic stroke and transient ischemic stroke. These are the indications of antiplatelet drugs. Then cardiovascular surgeries, CV surgeries, right? CV surgeries means maybe this could be the CABG, right? This could be the CABG, or for RHD, for VHD, for it could be in the kids also. So that things are, these are the indications for your antiplatelet drugs. And not only these, but these are extended to, as I told yesterday, peripheral arterial disease, peripheral vascular disease, or maybe the renal thrombolysis, renal stent thrombolysis, right? Thrombolysis, and that could be used in the DVT also. So these are the major indications for antiplatelet drugs. These are the major indications for antiplatelet drugs, guys. Okay, these are the major things. VHD is nothing but valvular heart disease. Surgeries for valvular heart disease. Okay, surgeries for valvular heart disease. So now this is the major classification. Here, look at the antiplatelet drugs. As I told you there also, first is COX inhibitor, and there is only medicine aspirin in that category. Another thing is P2Y12 receptor, that is cytochrome P12 Y12, P2Y12 as I was talking about. So in this, there are again two categories, guys. Okay, there are again two categories. Let me take you back to this side. Let me take you back to this side. When I am talking about the, see, okay, so there is no space to describe. Let me describe here only. Let me describe here only. So when we are talking about P2Y12 receptor, so this is again the platelet. Okay, this is the platelet, and there are ADP receptors. ADP receptors. These are ADP receptors. Okay, so one drug is coming and binding here for the permanent. okay, occupying this platelet permanently, so it cannot be occupied by the ADPs or ATPs released from the injured site. Okay, and this will end with the death of the platelet. With the death of the platelet, this will end. So this is irreversible. Okay, this is irreversible mechanism. Okay, this is the irreversible mechanism. So the drug particles are coming and attaching to the receptor. This is the irreversible process. But nowadays there are certain drugs which are attaching to this platelet ADP site, and for some duration only, just like 12 to 24 hours, 12 to 24 hours, and then detached from this area, and the platelet is now again free to flow in the circulation system, and it can work again anywhere else, wherever is the injury, outside the body or inside the body, anywhere. Okay, it is free to work. But in case of irreversible binding, the platelet will not be able to work or able to release the function whatever it is for. It will not be able to work again until it is dead. Okay, but in case of reversible process, in case of reversible binding, these platelet can be used again in the same process. Okay, so that's how they have divided the P2Y12 receptor blockers into two types: irreversible mechanism drugs and reversible mechanism drugs. So the first generation drug, which was ticlopidin and clopidogrel, first generation was ticlopidin was not so useful in this case, but clopidogrel was so useful, and clopidogrel is the first generation drug. Okay, first generation drug. Second generation is prasugrel, and these are the third generation drugs or the latest generation. Okay, 3G or the latest generation drugs. Okay, so clopidogrel, prasugrel are irreversible type of the drugs, and here ticagrelor, cangrelor are reversible type of drugs and more efficacious, and these are leaving the platelets for the other functions, other functionalities. Okay, that's how these are quite predictable and quite more efficacious than the first and second generation drugs like clopidogrel and prasugrel, because prasugrel and clopidogrel are having irreversible effect. Now I will connect it with the important side effect of clopidogrel and prasugrel and other drugs also. Guys, you will understand a lot of new things here. Why the bleeding happens? Usually, why the bleeding happens? Because when we are taking two antiplatelets or one antiplatelet also, and that antiplatelet is quite more active. There are, see, every person is different in case of mechanism and pathophysiology, right? Every person is different. So in some cases there is hypercoagulability. Okay, in some cases there is hypercoagulability. So in that case, in case of hypercoagulability, if we are giving clopidogrel, remember I'm just telling you the difference between clopidogrel and ticagrelor, or these two categories. Okay, these two categories means categories one only P2Y12 receptor inhibitor, but these two reversible and irreversible mechanism, why clopidogrel is having more bleeding than ticagrelor. So suppose when clopidogrel is bind to one platelet, so that platelet is now not free to function anywhere else. Okay, so the number of platelets goes down in the body. Activated platelets or the normal platelets, number of the platelet comes down in the body. And in case of ticagrelor, every 12 or 13 or 14 hours or 24 hours, the platelets are getting released to the circulatory system again from the drug particle, because that is detaching from the platelet surface, and those are again going to the circulatory system, and those can function as well as the new platelets. Okay, so that's why the bleeding is caused more in case of clopidogrel and prasugrel than the ticagrelor. Okay, that is why the clopidogrel and prasugrel has the high bleeding profile than the ticagrelor. Okay, just because of the irreversible behavior, irreversible binding with the platelets. Understand? Very simple to understand and very easy to understand, and it is important term to understand. Important term to understand. Okay. So one is aspirin, then P2Y12 receptor blockers, in that irreversible and reversible. So reversible are ticagrelor and cangrelor, and irreversible are ticlopidine, clopidogrel, and prasugrel. Now third is GP2b3a inhibitors. So glycoprotein 2b and 3a inhibitors. So how, like there are four drugs. One is abciximab, and then eptifibatide, and then tirofiban. So this is when we're talking about abciximab, so that is the actual monoclonal antibody direct from the body of the it could be coming from other synthesized, not, this is not synthesized, but that is coming directly from the sometimes from the cow, sometimes from the pig, and other goat, especially from the goat, right? Especially from the goat, it is coming from those spleens, right? Abscissumab. And but if I'm talking about eftimabine, eftifibatide and tirofiban, those are the synthetic molecules, but all those are GP2b3a inhibitors, right? And remember these three, like when I'm talking about GP2b, glycoprotein 2b3a inhibitors, those all are IV, and these all, including aspirin, are orally, PO. Okay, PO, oral drugs. This is IV. Okay, and fourth is phosphodiesterase inhibitors. So that is dipyridamole and clostrozole. So clostrozole and dipyridamole are not being used much. These are ancient drugs. If I say these are ancient drugs, but these contributes only 5 to 7% in platelet aggregation, only 5 to 7%. So not those, not that important, where aspirin contributes about around 70 to 80%. Okay, 70 to 80%. And P2Y12 receptors also, including around 30 to 40%, 30 to 40% of the binding process. Here this is 60 to 70%, sorry, this is 60 to 70%, this is 30 to 40%. Okay, that's why usually these two drugs are being used in platelet binding inhibition, or right, to prevent the platelet binding and to prevent the heart attacks or myocardial infarction indirectly. Understand? So now there are many things which I want to discuss with you. What is NCN drug is what? NCN is what? I don't understand this shortcut NCN. You can write the full form if it is. I did not write NCN somewhere, did I? Omer, I didn't understand NCN. You can write the full form. Okay, so guys, see. So I hope you understood here. Okay, I hope you understood here. Ancient, that is not NCN, ancient. Ancient means old drugs. The first line therapy which were introduced previously. Okay, which were introduced previously, and this group, I mean, dipyridamole is still there, but dipyridamole is not being used much, as the contribution is very less and side effect profile increases higher. Okay, not NCN, ancient, ANCIENT, ancient. Okay, that is ancient. No problem. That's fine. That's perfectly fine. So guys, this is the thing. Now I'll come to the things. I mean, this we have understood already. So I told you this, I've already described, with the platelets. So when there is plaque disruption, collagen comes out and von Willebrand factor comes out, and aspirin stops the platelet adhesion and secretion by stopping the thromboxane A2 at the platelet surface. And these other drugs are ADP receptors. So ADP receptors are also, ADP receptors are stopped by these ticagrelor, clopidogrel, ticlopidine, prasugrel, cangrelor, right? So because these are ADP inhibitors or P2Y12 inhibitors, these are P2Y12 inhibitors, right? So this thing is already understood. Okay, this thing is already understood. When the platelets are aggregated and collagen is coming to activate the platelets or to aggregate, then GP2b and 3a are playing the major role in acute cases. Okay, these are also stopping the platelet aggregation, and those drugs are abciximab and eptifibatide and tirofiban. Now my question here is first thing, let's discuss COX2 inhibitors. COX2 inhibitor, and there is only one drug, aspirin. Guys, tell me what is the dose of aspirin? tell me the dose of aspirin, everyone. Can someone write ADP and ATP full form for me here? 365 mg, I saw. Okay, so see, they have written, someone has written. Razvi Saha has written ADP is adenosine diphosphate and ATP is adenosine triphosphate. Okay. Okay, that's okay. We were asking about aspirin. So guys, let me tell you here, let me talk about aspirin. So suppose, let me give you a case scenario. Suppose one person has come with acute MI or ACS, acute coronary syndrome, to the TRICE. Okay, to the TRICE, or we also call it emergency room, ER, right? And ECG says this is STEMI. Okay, this is STEMI, right? And we have to give antiplatelet drugs. I'm just talking about aspirin. How much aspirin you will give right away? How much aspirin you will give right away before the patient goes for further procedures? Further procedures means angiography, which is the test, and then angioplasty based on the results of angiography, coronary angiography, CAG. Okay, so usual process is, if the patient comes with any kind of ACS, we go for CAG, like coronary angiography. This is coronary angiography, and then based on the results, like how many blocks are there, how many vessels are affected, then we go for PTCA or PCI, that is percutaneous coronary intervention or percutaneous transluminal coronary angioplasty, where we put the stents. Okay, where we put the stents, right? We remove the plaque and we put the stent at that side. But along with that, we have to give the drugs. So we usually start with two antiplatelets. So formula here is, let me tell you the formula here. Two antiplatelet drugs, two APLTs, right? Plus one what? Statin. Okay. And one what? PPI, and what? What other things? For the acute gastritis and all, we give multiple things, right? We also give the heparin or enoxaparin just during the procedure to stop the bleeding. Okay, but now we are just talking about antiplatelets. So two antiplatelet, when I'm talking about, first is aspirin. So what should be the dose of aspirin right at that time? 325 mg. 325 mg. Okay, 325 mg or 75 or 150. Okay guys, so choose out of these things, choose out of these three. Okay, I'm talking about aspirin here, I'm talking about the aspirin dose here. So aspirin 75 or 150 or 325. What is the aspirin dose? 150, 150, 150, 75, 150. Okay, so guys, let me explain you. Okay, let me explain the things. Whenever the patient comes for the first time before the procedure, or the patient is coming for the first time with the ACS or with the CAD, coronary artery disease. So first dose we give is called as the loading dose. Okay, loading dose, LOADING, loading dose. Okay, and then after first loading dose, only one loading dose, we give maintenance dose. Okay, maintenance dose okay, and maintenance dose means the daily dose, every time dose. So we start with the loading dose of aspirin and either clopidogrel or ticagrelor, whatever is to give to the patient. Either aspirin, I mean aspirin is definitely there. Along with aspirin, we can give the clopidogrel, we can give the prasugrel, we can give the ticagrelor. Any of these three, or cangrelor also. Nowadays cangrelor is available, not in India, but outside India this is available, right? So right now let's talk about Indian scenario. If we have clopidogrel, prasugrel, and ticagrelor, right? So these also are having the loading doses and maintenance doses. Okay, so can someone tell me what is the loading dose of aspirin? Okay, Suma has written 325 mg. Perfectly fine. What is the loading dose of clopidogrel? Guys, tell me, what is the loading dose of clopidogrel? Clopidogrel loading dose. 600 mg. My God. You will kill the patient for sure with bleeding. 600 mg people. No. Usually, when we are giving 325 mg of aspirin, we give 150 mg of clopidogrel. Okay, we give 150 mg of clopidogrel. Okay, and if I'm giving ticagrelor, what will be the loading dose of ticagrelor, guys? What will be the loading dose of ticagrelor? 180 mg. 180 mg is the loading dose of ticagrelor. Okay, and what is the daily dose of ticagrelor? Daily dose, write DD. If you are writing daily dose, write DD. Okay, okay. So let me tell you. Let me tell you. Let me tell you here. Let me tell you here. See, when I'm talking about aspirin, okay, this is aspirin. So aspirin loading dose is usually 325 mg LD, and maintenance is either 75 or 150 mg. Why this is? Depending on the patient's profile. Okay, depending on the patient's bleeding profile and patient's history of MI, right? So that depends on individual patients. Usually the loading dose is 325 mg and maintenance dose means daily dose is 75 to 150 mg per day. Okay, 75 to 150 mg per day. If I'm talking about clopidogrel, loading dose is 150 mg along with 325 mg, aspirin, and daily dose is also 75 to 150 mg per day. Okay, per day, right? This is the Indian scenario. Aspirin, if I talk back about aspirin, it is 75 in India only. Outside, that is 81 mg. Outside, that is 81 mg, and this 81 mg is known as baby aspirin. Okay, outside India, 81 mg is the lowest dose of aspirin, and that is known as the baby aspirin. Okay, baby aspirin per day 81 mg. Remember this, baby aspirin is 81 mg per day, which is not in India but outside India. Instead of 75, either in, if you go to Arab, if you go to Europe, if you go to United Kingdom or United States also, there is 81 mg, not 75 mg. In India, that is 75 mg of aspirin. But clopidogrel is 75 or 75 or 150 mg per day only, right? If I talk about Brilinta, Brilinta is nothing but ticagrelor. Brilinta is the company name. Brilinta is the brand name. Okay, ticagrelor is the generic name. So Brilinta or ticagrelor loading dose and maintenance dose per day is same. That is like 180 mg is the loading dose and 180 mg per day is the maintenance dose. So it does not come in the 180 mg, it comes in the 90 mg tablets. Okay, so in loading we give 2 tablets of 90 mg, and daily we give 90 mg in the morning, 90 mg in the evening. So loading dose and maintenance dose of ticagrelor is same. Okay, is similar, right? And if I talk about prasugrel loading dose is 20 mg and maintenance dose is 5 or 10 mg per day, once a day. So aspirin, clopidogrel or prasugrel, these are given once a day, but ticagrelor is given twice a day. Understand? So I hope you understood the things, understood the doses, and what's the difference in dose and maintenance dose and loading doses in the different patients, right? So now these are some indications. We know that if there is aspirin can be given orally, and the indications are risk reduction in ischemic patients, ischemic stroke, transient ischemic attack, stable angina, acute coronary syndrome means unstable angina, and STEMI and anSTEMI. When I'm writing ACS, that means either unstable angina, okay, unstable angina, or STEMI, okay, or anSTEMI. These all three are coming under the ACS, acute coronary syndrome, right? So, and then peripheral arterial disease. Major side effects, major adverse effects of aspirin, high dose is GI bleeding, okay, or maybe hemorrhagic stroke also it can cause. It can cause hemorrhagic stroke also. So, guys, tell me, higher dose of aspirin is beneficial or risky? Tell me if it is beneficial or risky. Higher dose of aspirin, higher dose of aspirin, higher dose of aspirin, high impact or high efficacy. Is it right or wrong? Risky. So with the higher dose of aspirin, it does not make any sense on the efficacy. Efficacy will be lowest only, and there will be the higher risk of bleeding if we are giving the multiple things. So when we are giving the aspirin, there are multiple chances of GI bleeding and hemorrhagic stroke. And when I'm coming to ADP receptor blockers, this clopidogrel, again, these all the ADP receptors are orally, right, oral drugs, and given in different indications. Major adverse effect is bleeding, abdominal pain, diarrhea, right? And one more major adverse effect of aspirin I forgot, that is gastritis. Okay, gastritis. Major side effect of the aspirin is gastritis also. Okay, that's why we always attach PPI when we are giving aspirin, right? We give PPIs also whenever we give aspirin to the patients, right? So ticagrelor, again, bleeding risk is there. And when we are giving ticlopidin, there are the chances of thrombocytopenia. Oh, so sorry. Okay, so one sec. Okay, so when I'm talking about ticlopidin, there are the chances of thrombocytopenia, neutropenia. Okay, so usually we don't give ticlopidin much. We give clopidogrel, or in the latest drugs, ticagrelor, because ticagrelor is reversible behavior. Okay, ticagrelor is having reversible behavior. Okay, now, if we are talking about PDE inhibitors, phosphodiesterase inhibitors, cilostazol or dipyridamole, again, both are PO given orally, and their risk are not usually bleeding, but hypotension sometimes, and headache and dizziness. But as we are saying, there is only 5 to 7 to 10% of the benefit of these drugs. We don't give much. Okay, when we give, there are certain parameters, there are certain circumstances when we give dipyridamole, where there is the patient who is not able to take aspirin, okay, who is not tolerant to aspirin. Then in such cases we give dipyridamole, okay, just to increase the benefit in platelet aggregation stoppage. Okay, so in the cases certainly where aspirin is not tolerable, we give dipyridamole or cilostazol. Cilostazol is quite new drug, and it has the good efficacy than dipyridamole, so it helps in the better ways, right? Now, if I talk about GP2b3a inhibitors, so abciximab is there. Abciximab, again, it is like these all three, as I told, are given in the IV form, intravenous. Okay, intravenous. And why? See, if I'm talking about these GP2b3a inhibitors, GP2b, what is glycoprotein? Glycoprotein is the integrin. Okay, glycoprotein is actually the integrin. As I told you, this is attached to the platelet surface. Okay, platelet surface. So integrin means the receptor. Integrin is the name of protein. Integrin is the name of protein which is attached to the platelet surface and catching the collagen. Okay, catching the collagen and attaching all other platelets and the same platelet to the injured site. So to stop that, to inhibit that, in the urgent cases, we have three drugs: efzimumab and eptifibatide and tirofiban. And these adverse events of these three drugs are excessive bleeding if not given in the counted dose, and like there are multiple other bleedings from GI and urinary tract as well. Okay, so excessive bleeding is the major side effect of these, and these are given only in certain cases, right? Only in certain cases. So can someone tell me where we should give GP2b3a inhibitors? Right, guys, tell me when we should give GP2b3a inhibitors. Anyone? So yeah, someone is writing. No, unstable angina. No, yeah. See, indications are written here only. Why I'm asking the indications? I'm not asking the indications. I'm asking the circumstances. Okay. I'm asking for the circumstances. Indications are there in your, in front of your screen. Okay. In front of you only on the screen. I'm asking for the circumstances. So circumstances are during the procedures, usually during the procedures, because if I'm talking about tirofiban and efzimumab, there, tirofiban and eptifibatide, their T half is quite high. Okay, quite high means not as the oral drugs, but it is like for the procedure, during the procedure, this start acting within seconds. First of all, these starts acting within seconds, and the T half is around half an hour to 2.5 hours. Okay, T half is half an hour to 2.5 hours. So this is the ideal time to do the procedures. Like this is the ideal time for the procedures like long term, the bigger treatment procedures like PTCA and PCIs. So in certain procedures where we have the risk of clot formation, certain during certain surgeries, and like certain surgeries in CABG, or maybe during the percutaneous transluminal interventions, we give these drugs during the processes. Okay, right now these drugs are not allowed to give for the long term on the follow-ups. Okay, these drugs are not allowed to give for the long terms for the follow-up. Understand? So now let's learn about a little difference between the drugs, little science about the trials. So when we are talking about clopidogrel and prasugrel, so you can see here hazard ratio. Okay, hazard ratio, if I talk about the, see, look at this. This is the hazard ratio events. Number of the events are higher in clopidogrel than prasugrel. Okay, but when we talk about the safety points, safety point again is quite good, quite better than, quite better in clopidogrel than prasugrel. Okay, quite better in clopidogrel than prasugrel. Okay, and hazard ratio is higher in prasugrel than clopidogrel. Hazard ratio is higher in prasugrel than clopidogrel, and safety is better in clopidogrel than prasugrel. Okay, remember this. Why? Because prasugrel has the limited indications, and clopidogrel can be given in multiple occasions. So usually if someone asks you, clopidogrel has the, clopidogrel has the higher bleeding profile than the prasugrel. But if we talk about the efficacy and hazard ratio, prasugrel has the higher hazard ratio than clopidogrel in case of long-term endpoints. Long-term endpoints. Okay. So if I talk about Brilinta and aspirin plus clopidogrel and aspirin, so like ticagrelor versus clopidogrel, so you can see clopidogrel has 11.7% events. Okay, events means either CV death or stroke or myocardial infarction, recurrent myocardial infarction. Okay, so with clopidogrel, the risk is 11.7%, and with clopidogrel, it is just 9.8%. And that is highly significant if we see hazard ratio is 0.84 with clopidogrel. So ticagrelor is far better efficacious than clopidogrel. Okay, ticagrelor is far better efficacious than clopidogrel, and it also has the better bleeding profile than clopidogrel, and it is behaving, or it has the reversible mechanism with the platelet, mechanism of binding, reversible mechanism of binding. So it has the better profile, better efficacy than the clopidogrel. It is quite costly, of course. Now the cost has come down, but still it is 30 rupees one tablet or something, 35 rupees for one tablet, and clopidogrel is just a 1 rupees per tablet. Okay, but the efficacy and long-term events are quite lesser in the patients than the clopidogrel. That's why Brilinta is quite better than the clopidogrel. Okay, guys. Now, if I talk about all these three drugs, GP2b, 3A inhibitors, first is abciximab, and then eftifibatide, and then tirofiban. So let's not go into the molecular weight and other things. Let's talk about half time. Okay, so abciximab has the plasma half time of just 10 to 15 minutes. Okay, and at the other hand, as I told, eftifibatide and tirofiban has the plasma half-life of 2 to 2.5 hours. Okay, 2 to 2.5 hours. That's why these are better than the abciximab. But abciximab is the actual antibody, but these eftifibatide and tirofiban are synthetic peptides. Okay, synthetic peptides. Now, if I talk about dose, the bolus dose is 250 microgram per kg for abciximab, and for these eftifibatide, it is 180 microgram per kg. Okay, and for tirofiban it is just 25 microgram per kg. Okay, dose I'm talking about, dose we can give, like for abciximab it is 250 microgram per kg, for eftifibatide it is 180 microgram per kg, and for tirofiban it is 25 microgram per kg, right? And infusion can be given at the rate of 0.125 microgram per kg per minute for 12 hours. And for eftifibatide, it could be given as 2 microgram per kg per minute for 12 to 24 hours. And tirofiban can be given only 0.15 microgram per kg per minute up to 18 hours. Okay, so these are the dosing in percutaneous, in the case of heart attacks, right? And we don't need any kind of renal adjustment in case of abciximab, because this is the real antibody, this is the antibody, this is the original antibody, and these two are synthetic, so these have the effect on renal failure, I mean kidney, right? Kidney, these are having the problem with kidney. Okay, so there we need the adjustment when we are giving in the patients with renal failure. When we are giving in the patients with renal failure, we need the dose adjustment. One more thing, why abciximab is better in case of, just in case of renal adjustment and all, we usually, why we prefer abciximab over these two when it comes to the secretion. See, in patients of kidney problems, this is very important to learn, guys. In patients of CKD, okay, or AKI also, okay, in patients of CKD and AKI, we prefer abciximab. Why it is? Because see, when I'm talking about eftifibatide and tirofiban, 50% of the drug, both 50% of both the drugs are secreted from the kidney. Okay, and 50% remains in the body and goes with the time, and it causes the toxicity. Okay, it causes, these drugs causes the toxicity of kidney. But when I'm talking about abciximab, then what happens is 50% is secreted from the kidney and 30% is secreted in the bile, means from the liver. Okay, that is the advantage with abciximab. This is the advantage with abciximab, and that's why in the cases of CKD and AKI, we prefer abciximab over eftifibatide and tirofiban. Understand? So that is all for today's class, and I hope you learned about antiplatelet drugs, and we have two more categories in this. So this is all about antiplatelet drugs and coagulation cascade. So now guys, AKI means acute kidney injury, CKD means chronic kidney disease or chronic kidney injury, CKI. Okay, so now I'm open for the questions, guys. You can ask me the questions. I'll share the PDF, don't worry. Okay, I hope you liked the class, you enjoyed the class today. All the classes will be like that only. Cardio 3 is cardio 4 is my favorite. So you understood, guys? Any questions now? Please ask me if any questions. Oh, why are you worried about exam, guys? Come on. Exam mostly will be in MCQs only, definitely. So is there any dose adjustments? Yes, dose adjustments are there based on the kidney failure, based on the stage of kidney problems. So we adjust the doses of eptifibatide and tirofiban, but there is no need to adjust the dose of abscesmab. Okay, and there is no dose adjustment for aspirin, clopidogrel, ticagrelor. No need of dose adjustment because those are not having much effect, or those are not having the direct effect on the kidneys, CKDs, right? And yes, aspirin is also given as anti-inflammatory. And guys, one more very important thing I want to share here is, like, see, okay, aspirin is also given in one more thing. So another indication I forgot to tell you, another very important indication for aspirin. Okay, aspirin is, RHD, rheumatic heart disease. Okay, rheumatic heart disease. Okay. And can you tell me what is the dose of aspirin there in rheumatic heart disease? Rheumatic heart disease is nothing but the inflammation of cardiac muscles. Okay, inflammation of heart, we call it. Tell me the dose of aspirin in rheumatic heart disease, guys. Yes. See, we usually understand, and in the case of myocardial infarction and all, 600 mg of aspirin is the last. Otherwise we have the risk of excessive bleeding. But in case of RHD, we can give up to 304 tablets 4 times in a day. 300 mg, 325 mg actually, 325 mg, 4 tablets all together for 4 times in a day we can give. Okay, can you imagine that? 3 into 4, 12, 12 into 4, almost 3 to 5 gram or 3 to 5 gram per day of the aspirin we can give in case of RHDs to suppress the inflammation. Okay, 3 to 5 gram per day we can give to the RHD cases. Okay, and for sure, we have seen very rare cases of bleedings in RHDs. Okay, there is no bleeding cases of bleeding cases in RHD, even with this excessive dose, this very high dose of aspirin. Okay, that is the another thing. What is the creatinine clearance of Okay, so that's the question for you, Archana. Creatinine clearance of aspirin. Usually, we don't need any dose adjustment for aspirin. Okay. Yes, guys. So that's all. Okay, that's all for today. Please ask me your questions if you have any. Okay. What should be done in patients with both ischemic and hemorrhagic strokes? Oh, there are usually not in the combination, first of all. And if there are different mechanisms. There are different strategies of the treatment, like first of all hydration, and then control of hemorrhagic stroke one by one, surgeries, and low dose of clopidogrel. Okay, I'll tell you in that case, don't worry. Yes, you can do, Akhil. Okay, why aspirin should not be given? Why aspirin should not be given? Who told that is not given? Aspirin is given with the P12Y, P2Y12 inhibitors or cytochrome P inhibitors. That is given. Okay. Is it safer for geriatric patients to take ticagrelor instead of clopidogrel? Yes, ticagrelor is having the better effect and better safety profile than clopidogrel. So we give geriatric patients, we give the geriatric ticagrelor in geriatric patients as well. We usually give. I'll tell Akhil that you can ask me in person. Later, you just message me personally. I'll tell you the colleges and all, name of colleges. Okay. Okay. So guys, take care and have a good night. Take care. Okay. So one more announcement. I'll be taking your classes tomorrow also 8 to 9 p.m. and day after tomorrow also 8 to 9 p.m. because next week and next to next week I'll be traveling again. Okay. I'll be going to Chandigarh and Delhi and Hyderabad to deliver some lectures there. So I'll be taking your classes tomorrow and after tomorrow also. So I mean, it's even good to continue the classes and yeah. Okay. So tomorrow 8 o'clock, day after tomorrow also 8 o'clock class. Okay. Take care, guys. Thank you. Good night, guys. Bye bye. See you.